All right, so we're going to start with the care of the diabetic patient, still looking at medications, but now we're going to look at insulin. The primary goal of insulin therapy is to mimic the physiological insulin secretion found in the non diabetic person. Remember, insulin is a protein. It's inactivated by the GI tract, so it has to be given either sub-Q or IV. Basal is the constant amount of insulin from the pancreas that delivers balance the liver glucose production with glucose use and maintenance normal blood glucose levels between meals. Remember, all type 1 diabetics need a basal insulin. Prandial or bolus insulin is given to prevent blood glucose elevations after meals. Now, the same is true as far as with the prandial boluses of insulin after meals is where you'll see a lot of times your type 2 diabetic patient. Sometimes they will be placed on, once they get them under control, a lot of times patients with type 2 diabetes will be placed on a long-acting insulin that's given at night for their basal, so to speak. And then they use a shorter acting or an immediate acting insulin during the day with a sliding scale. Based upon what their blood sugar is, determines how much insulin they get. And they take the recordings of these findings with their blood sugars to their endocrinologist a lot of times to determine if sometimes their long acting needs to be increased. So these are ways that a type 2 diabetic would use insulin. But remember, with a type 1 diabetic, all type 1 diabetics need a basal insulin. Not all type 2 diabetics need a basal insulin, but if they if their pancreas has started to tucker out, it isn't working as efficiently, sometimes they are on a long-acting insulin and then take bolus of insulin to prevent blood glucose elevations after meals, just like your type 1 diabetic. But remember, all type 1s are on a basal, but not all type 2 diabetics are even on insulin at all. Insulin pumps are used by a lot of type 1 diabetics and some type 2 diabetics that are requiring both basal and bolus insulin. There are several types, and every week there seems to be a new type. They only use rapid acting insulin, and it's based on a bolus basal concept. And what the patient does is they put in what their blood sugar is, and then the machine tells them what they need to do with their insulin, and they move it up and down accordingly. Most of the time, they're taught how to use this by the diabetic educator at the endocrinologist's office, and it really does very well at controlling their blood sugars. Pretty because as soon as they dial it in, so to speak, it gives them that insulin and reduces their blood sugar. A lot of patients like this because they don't have to stick themselves as often for their insulin dosing. So why do we need so many different types of insulin? It's because they work at different speeds. And take a look at the table on 64-8 and the chart on 64-3. And it talks about the different types of insulin. The rapid insulins are used a lot of times for sliding scales. They're used in the diabetic insulin pumps. Short acting is an older insulin. It has a longer uptake time. We'll talk about that in a few minutes. Then there's intermediate insulins, and then there's long acting insulins that can be used as a basal dosing for a patient. I know some of you have not finished pharmacology yet for my 492 guys, so I will not talk specifically about the name, the brand, or the exact type of insulin, but you will need to know about the rapid acting, regular, intermediate, and long acting insulins, but you don't need to know the specific by specific name, excuse me. So now let's talk about the care of the diabetic patient, factors that influence insulin absorption. Now this can be for a patient with either type 1 or type 2 diabetes. They have to make sure that they're rotating their injection sites. There's a pretty picture for that on it's figure 64-3. They need to rotate their sites. They need to make sure that they are at the correct depth and that they are giving it into subcutaneous tissues, that they're, especially type 1 diabetics who tend to be thinner. If they're giving it into their arm, make sure that they're actually getting it into subcutaneous tissue and not just into skin, or if they're muscular, into muscle. Either one of those would interfere with the absorption times, so you want to make sure that you're giving it into the subcu tissue. Injection timing is based on the patient's blood sugar, the type of insulin. Just remember that the time between the blood glucose level and the insulin injection is called the lag time. If a patient is using regular insulin for their prandial insulin or their sliding scale insulin, remember that when the blood sugar is in range, they need to take the regular insulin 20 to 30 minutes before the meal. Now, if they're hypoglycemic, you want to delay the administration until immediately before eating. If they are hyperglycemic, with the lag time increase to allow for regular insulin to start working prior to the food actually hitting the stomach. So you need to, at this point, you would need to follow policy or contact the provider. Most of the time with this, they may choose to do a different type, a different dosing of the insulin. In my practice, I don't really see regular insulin being used for prandial insulin very much anymore. They mostly use the rapid, but I do know for patients where cost is a factor, regular insulin is much less expensive. So I think that's where you see a lot of people using the regular insulin for their prandial or sliding scale insulin. The rapid onset insulins, this is when the blood sugar is in range. They need to eat within 10 minutes. If they are hypoglycemic, you might need to be delayed until after they eat. Again, you would need to follow the policy at the facility you're at or to contact the provider. And if they're hyperglycemic, you need to follow the policy or contact the provider. A lot of times, again, these people have, it's a sliding scale, so you give more if they are hyperglycemic, and you would just go ahead and give them their medication. Most facilities have if the blood sugar is this, you do this type of policy, so you don't really need to contact the providers. But if the hospital or facility you're working in doesn't have a policy such as that, or an order for your specific patient, you would need to contact your provider. And of course, if the patient is symptomatic with their hypoglycemia, you would not administer the insulin until you were able to get that blood sugar up some. We're now going to talk about mostly your type 2 diabetics, because we're talking about anti-diabetic medications. When diet control is no longer sufficient or the patient is highly symptomatic, remember, a lot of times with anti-diabetic medications, they're on a combination of medicines. Short-acting drugs are preferred for older patients or patients with irregular eating schedules, and those with, and those with liver, kidney, and cardiac functions. You know, a lot of times our older patients may not be on such a set schedule with their meals, and it's harder for them to eat at the same time every day. Perhaps the patient's lifestyle or career does not allow them to eat at regular intervals, and this is where a short-acting medication would be more beneficial than one that they have to take, that they may only have to take the medication once a day, but they have to make sure that they're eating at regular intervals. So if they are in a position where they were not able to do that, this could cause hypoglycemia. So short-acting drugs are used both for the elderly and also for patients with irregular eating schedules. And, you know, just keep in mind that your short-acting is a little bit more flexible, but they have to take it more often. And the long-acting doesn't have as much flexibility, but they only have to usually take it once a day. And a lot of times with the longer acting being a once-a-day dosing, there's better adherence to it. And again, this is all about the type 2 diabetic. So you really just have to kind of know your patient, and the provider has to discuss the patient's care with them. You know, the provider may be thinking, well, the long acting, they only have to do it once a day. They wouldn't have to take it with them to work. But maybe the patient is a emergency department nurse who has no clue when she's going to get lunch. You don't want to put her on him on a long acting medication when they don't know if they're going to get lunch at 11 or lunch at 1. Same thing with your elderly patient who, may sleep in and not eat breakfast until 10, so they don't eat supper until 2. Well, they decide just to have a snack. So the shorter acting medication works better for that populace as well. I hope that makes sense. Now we're going to talk about self-monitoring blood glucose. Self-monitoring of blood glucose is necessary to assess for the effectiveness of current regimen and to assist the patient in self-care decisions. Most patients keep a log or they bring their meter in for appointments to be downloaded. Frequency depends on patient condition and on the medication regimen. Frequency of when they need to check their blood sugars. The accuracy of the blood glucose monitoring is usually, if there is an error, it's user error. Most common error is user error. Sometimes it's that they don't use enough blood. Sometimes they don't rotate their fingers and the finger becomes calloused. And so even though they're getting a drop, it's got more serum in it than actual blood. So if it doesn't have that blood in there, and it's just the serous fluid, you're not going to get a good blood sugar. It could be poor storage of strips. Do they keep them in their car? Do they, keep them in their gym bag? Or they, these strips are very expensive, and sometimes patients will use expired strips, or they don't purchase the QC stuff to do their blood glucose machines, or they don't clean them correctly. So usually the accuracy of blood glucose monitoring, if there's a mistake, it's usually user error. Just as an aside note, this will not be on the exam, but a lot of times you have to be very cautious, especially with your type 1 diabetics as they enter their teen years. They will do things to manipulate their blood sugars. 100 years ago, when Moses was a small child and the earth was still cooling and I was in high school, I had a dear friend who was a type 1 diabetic, and she would put her finger in ice water so that when she stuck it, it would get more of the serous fluid and not as much of the blood, the red blood cells, so that her blood sugar would be lower. It's not smart, but kids can do strange things. Or they would stick their friends, I know friends of mine's children have had issues where they, will get their friend's blood instead of theirs so that their blood sugar is normal because they, ate a Reese cup or had a sun drop or what have you. So that's with your type 1 patient. That won't be on the test. But just keep in mind that usually blood glucose monitoring, if there's a mistake in it, it's usually user error. And there are ways to manipulate the machines. A little devious, but there are ways to manipulate the machines.